Hello, my name is Avrika Savitskaite. I'm a co-founder of helmetbasedventilation.com. Today we have a guest, Dr. Owen O'Neill. He is the president and CEO of US Hyperbaric, America's leading commercial diving and tunnel medicine team. He is the founding medical director of the Department of Hyperbaric Medicine at Phelps Hospital and participating the specialty for greater than 30 years. He is an associate professor of medicine at New York Medical College and an associate professor of emergency medicine, Division of Undersea and Hyperbaric Medicine at SUNY Upstate Medical University, where he provides multiple chamber training for the Undersea and Hyperbaric Medicine Fellowship Program. Also, he's lecturing on topics in diving and hyperbaric medicine, not just in US, but also internationally, and recently edited and co-authored the first edition of Policy and Procedural Guidelines for Hyperbaric Facilities. He also is the recipient of 2018 UHMS Commercial Diving Award. Oh my God, I feel like I said a lot, but probably not enough.
I feel like saying, who are you talking about? Who is that guy?
Well, I'm very happy to meet you. I actually met you last week during the webinar where you presented your study on helmet-based ventilation. And I'm very glad that you can do that presentation here with me for our viewers. So I will let you talk about the study, and if you can share your slides, we can talk about that. And then I have a few questions about the study and how the implementation happened and the idea where it come from and everything.
I'd be happy to do so. So let me just go ahead and share my screen here with you. Mm-hmm. And can you see that screen now?
Yes, perfect.
Okay, good. So our study with the hoods was actually begun around the beginning of April when we had a very high incidence of COVID in the hospital. And we had talked about the use of the oxygen hoods because the hoods were one of the only ways we could guarantee a patient to receive 100% oxygen without any leaks. And we also felt it might be a good way of protecting people against the virus because it was a closed system. So I'll go ahead now. We'll just give you a little bit of an idea of what we did. And if I can, let me see if my slides will switch, and they will. So we'll talk about how it was used with success in the past just a little bit. Norika can probably help us with that more than anybody. The high numbers of patients that required mechanical ventilation, limited supply to meet high demand. These are all reasons why the hood would be a good choice. We needed to meet oxygen demand in patients, right? The actual amounts are currently under debate, i.e. maybe less than 100% oxygen might be better than 100% oxygen. But we did want to try and delay intubation, and by delaying intubation, that would certainly allow us more time to try and secure any of the resources that were needed for intubation, mechanical ventilation, and other high flow devices. But the main reason we wanted to do this was to try and delay or prevent intubation because we know that the significant mortality that was associated with intubation was up in the 76 to 97% range. So high flow measures do not guarantee the delivery of 100% oxygen, right? We have a nasal cannula in somebody, we have a mask. These people can breathe in room air around that. Also, leaks occur around the mask and the nasal cannulas. And then there was also the significant increased risk of airborne virus spread, especially when using a high flow device. So using the hood with the neck dam and the neck ring, the neck dam is going to basically seal the patient's neck similar to a turtleneck, and then the hood would come down over on top of the neck ring, creating a completely closed system. So this system, of course, is more likely to deliver 100% oxygen. And there was actually a study that was performed at Duke University which showed that it takes about 3 minutes for the hoods to completely fill with 100% oxygen. Contains the virus when coughing or sneezing, whereby what? Decreasing the risk of airborne transmission to hospital team members. and decreasing airborne dissemination during transport throughout the hospital, because that's always a significant factor, how patients are going to be transported, where they have to go, what's significant, what's necessary, and how we're going to best decrease the spread. And certainly keeping them enclosed in a hood would be a lot better than just placing the mask over them. So who gets to try the hood, and what parameters should we use to make that decision? Well, these were all decisions that were being made on the fly. This was all new to everybody. So patients approaching the point of clinical respiratory failure that were going to be soon in need of intubation and mechanical ventilation, those were the initial patients that we were called for. So we used a oxygen saturation of less than 90%. And of course, the clinical status of the patient, how bad do they look? How tachypnic are they? Do they look like they have various stages of respiratory failure? Now, people ask me why I decided to use 90% as a reason to go ahead and try the hood. And that's because if you look at the oxyhemoglobin dissociation curve, 60 here, the PaO2 at the bottom of 60 represents the baseline lower value of normal. So less than 60% is considered hypoxic, or not enough oxygen in the system. And if you move the oxyhemoglobin dissociation curve to the left, you become progressively more hypoxic. So if you go up here and look at this 90% saturation where the arrow is now, we always in the past used to give the nurses the orders in the ICU to say, okay, let's give the patient enough oxygen to maintain their saturation at 90% or above. And I know now the values are a little bit higher, about 92 and 93%. And the reason why we used 90 in the past is because 90 would correspond to about a 60 PaO2. So we know that if we have a saturation, oxyhemoglobin saturation above 90%, then we know the patient is not hypoxic. So that was our decision to use a 90% saturation. So patients that had an SaO2 of less than 90%, already on non-invasive positive pressure ventilation, those were the patients that were referred to us in an attempt to try and either avoid or delay mechanical ventilation. So these cases represented the sickest of the non-intubated patients with impending respiratory failure and the imminent need for intubation and mechanical ventilation, had the use of the oxygen hood not be available. Okay, so these are the people, if they didn't have us to call to try the hood, they were getting intubated. So in our hospital, to be honest with you, we had approximately 3 high flow oxygen meters. So we had a very low supply. So we had to use the wall oxygen supply in the patient's rooms. All right. So all the patients that had COVID, the hospital was fast enough to adapt negative pressure rooms in the majority of the rooms in the hospital, which was amazing how fast they got that done. Our safety director, John Sullivan, went down to Home Depot with some parts from the hospital, et cetera, and he figured out how to put this adapter together so we could connect the hyperbaric hood helmet tubing up to the wall oxygen flow meter. So we affectionately call that the Sully adapter after John Sullivan. And I can tell you Home Depot was also very nice to us, because when he told Home Depot what he was actually doing, they gave him all the parts for free.
Wow.
So, yeah, it was a very nice thing for them to do. So the hoods require a high flow rate, and I say here minimally set at 30 liters. I think most people looking at 40 to 60 liters as a minimum flow rate, and the reason we do that is to make sure we're ventilating off enough of the CO2. We don't want CO2 build up inside a closed hood system. The higher the flow rates throughout the hospital also required the main oxygen supply to be increased to support the high flow demands. And the way this hospital is set up, a lot of our oxygen piping was old, so we really could not handle more than 12 high flow devices per floor. So we had to actually go out and readjust our oxygen flow meters. HEPA filters were placed on the oxygen hood exhaust with a reported bacterial viral filtration efficiency equivalent to about 99.99. That further mitigated the exposure risk to the team inside the room, even though it was a high pressure flow, negative pressure flow room. excess oxygen released from the exhaust manifold of the hood is vented from the negative pressure rooms, further mitigating the risk, as I just mentioned. The transparent oxygen hood also allowed for decreasing aerosolized contamination of the room and the people working right around the patient, and also provides good visual assessment of the patient's head where he's not being actually covered up by a mask. So for outcome assessment, we recorded the oxyhemoglobin saturation prior to putting the hood on the patient, and after putting the hood on the patient, we gave him 10 to 15 minutes to equilibrate. Endpoints were discharge versus in-hospital death. So the patients who got the hood, besides looking at the SATs, how we improved them, we would look at whether or not they were discharged or whether or not they had an in-hospital death or intubation in control and intervention cohorts, both of them. So in-hospital expirations that were DNR were reassigned to the intubated group. Now, I did notice that one of the studies I was looking at, or one of the indications to use these hoods, someone had mentioned out there that one of the reasons to not use a hood is if somebody was a DNR and refused to be intubated. I don't think that's a good reason to not use the hood. The idea of using the hood is to prevent intubation. So if they don't want to be intubated, I think then the hood is the last resort. So I would not, if you read that anywhere, I would not use that as a reason to not put a hood on a person if they're DNR, i.e. they don't want to be intubated. I would go ahead and put the hood on those patients and see how they do.
Agree. Yeah.
So pre and post oxygen difference on the hood were also recorded, the O2 difference. Intubation, mechanical ventilation status, we would note if the patient on the hood was intubated at all or not. The survival and mortality, whether they expired, and the hospital length of stay. Okay, randomization of course was not possible. This was a new thing, this was a pandemic, and it would be considered unethical to randomize someone to not get the hood if we thought the hood was going to be beneficial for them. So with all that said, here's what we found. We found that we put a total of 136 patients into the study. 58 patients received the hood. 78 patients were the control patients, and those are the patients that were being seen prior to us using the hoods, or anybody who was considered to be a DNR, because those patients would have been patients who would have been intubated that refused everything. Mm-hmm. The hoods averted imminent intubation 100%. So when I say that, I tread cautiously. What that basically means, if you remember, I said that we were going to be called for the patients that were about to be intubated. So they were not maintaining a saturation above 90. They were having respiratory difficulty, where by any other means we would have just said, okay, it's time to intubate this patient and put them on mechanical ventilation. Those were the patients we put the hood on. So those patients did not require immediate intubation 100% of the time. So we were able to either avoid or delay intubation. Mean improvement in the post-hood saturation was 8.8%. And I just want to point out that averting imminent intubation 100% of the time held a statistical p-value of 0.0001. This was just another way of looking at it. Now, if you look down to the left, I kind of highlighted this 83%. And this is going along with what I said earlier with, we don't know if needing to keep the patient's saturation above 90% is absolutely necessary, right? We know that having high concentrations of oxygen in the alveolar system in the lung can cause damage over a period of time. So my anesthesiology and critical care colleagues are saying, well, maybe we can lower that need, maybe we can lower it down. So we went back and looked at our data. We found that the patient with the lowest SaO2 that did well on the hood was 83. So it was 83% minimum saturation. And the maximum, of course, we brought people back up to 100. So that one person who had a minimum bad saturation, we put him on the hood, his sat came up to 83 only, but avoided intubation. Okay. So that was that one patient, which kind of throws the wrench into the spokes. Do we really need to use higher saturations when we're looking at improving these patients? So looking at the mechanical ventilation rates, the controls 37 of 78. So the patients who we did not get the hood, 37 of those patients wound up being intubated for a 47% intubation rate. Of the 58 patients that got the hoods, only 23 of those needed to be intubated for an intubation rate of 39.7 with a difference of about 7.7%. So we achieved a 27% risk reduction of the need for intubation, right? And the problem was with this is that it wasn't statistically significant. All right, so you see my confidence intervals there are 0.37 to 1.5. So we crossed over the 1 value. All right, so although we didn't reach a level of statistical significance, we did have a 27% risk reduction. Right, so you can't argue with that. And keeping in mind,
which is very high for the COVID patients. We
yes,
have to keep that in mind that these all patients have COVID, right? Is that
right? And you know, keeping in mind the most important thing is when we look at intubating these patients, they have up to a 97% mortality rate.
Yeah.
So we really want to try and do whatever we can to prevent people from needing intubation. So looking at the mortality rates of the control group that did not receive the hoods, 54 of the 78 controls had died, which gave us a mortality rate of about 69.2%. Versus the intervention group that got the hoods, that mortality rate was 62.1% with a difference of 7.7. And again, a 27% risk reduction in mortality. Okay, but again, not statistically significant. Confidence intervals were 0.36 to 1.5. So again, a good risk reduction, but not to the point of being statistically significant. And again, I think this is because we were dealing with the patients that were imminent respiratory failure and needing intubation. So we have to take that, I guess, for what it's worth. So in conclusion, what we found by doing this small study was that oxygen hoods did demonstrate improvement in the SaO2 significantly and statistically, prevented people from needing immediate intubation. And then mechanical ventilation and mortality rates were reduced by about 27% by using the hoods, although that did not reach a level of statistical significance. So I think we have a lot more information to collect here. I think that if we do a multi-center trial with this also, unfortunately, back then we could not do a randomized trial. And I think one thing we can certainly do this go around, if we had enough interested individuals, was to do a randomized trial with conventional non-invasive positive pressure ventilation versus getting a hood.
Yeah, and it's just the timing, like you mentioned, it was pandemic, and it's
right.
This pandemic, and you just to do a study during the pandemic is extremely hard. It's the same what I'm hearing from Italian studies. The quality is not the best just because everybody was trying to do, you know, everything what's possible to save these people. And, you know, like you said, you cannot do the randomized because you don't want to, it just would be unethical during the pandemic to do that. So definitely more data needs to come, and, you know, maybe collaboration with other colleagues who are using helmet-based ventilation. So thank you for presenting that. And I have a couple of questions from, you did mention that you used it for the transporting patients in a hospital.
For transporting. Well, we didn't use it just for transportation, but the patients that had the hood on, if they needed to be transported, we'd left the hood on.
Okay.
We had also had presented to our internal review board a study to do hyperbaric oxygen treatments on these patients as well. Unfortunately, it got turned down by the IRB. We then presented it to our own administration. Our own administration was positive. They wanted to do it.
Mm-hmm.
So unfortunately, at the same time, we got permission to use hyperbarics for the COVID patients. The hospital entered the convalescent plasma trials through the hematology department, and the hematology department fortunately for them, came with a research assistant, something we don't have in the Department of Hyperbaric Medicine. So we had to get up there before they did to get consents, because our inclusion criteria were pretty similar. But if we used hyperbarics, they couldn't get convalescent plasma. If they got convalescent plasma, they couldn't get hyperbarics, because it would be competing with one another in a trial. So they managed to beat us all the time up to the floor with the new patients coming in that were going to be getting convalescent plasma. So we weren't able to do that, but the hoods, we at that point were saying it would work out fine if they're in the hood for transport, because we can connect the hood to high flow oxygen for the transport, which is 5 or a 10-minute run down to the hyperbaric department. So the oxygen tanks would last to get the patient down to hyperbarics. Once we got them down there, we could put them right into the chamber and just reconnect the tubing from the oxygen tanks to the hospital hyperbaric system. So it would have been a smooth transition without the patient blowing any germs all over the place, right? And no viral components, because they'd be in their closed hood system the whole way down during treatment and the whole way back to their room and then back into their room again. So there would be no spreading of the viral bacteria through saliva, let's say, while they're in the hood.
So now, how long patients use the helmet? What was the longest time that the patient had a hood on, and how did he tolerate it?
Right. Well, the concern, of course, is delivering high flow oxygen at 100%. And that's what we were doing. So if we were able to adjust that percentage of oxygen, it would have been better for us and probably better for the patients. But we used the criteria of, again, looking at the patient's comfort in breathing, as well as looking at the O2 saturation. So if they were maintaining an O2 saturation greater than 48 hours on the hood, we would try and convert them back either to some other type of high flow device or a nasal cannula or a mask, and see if they could maintain their saturation. But I think going forward, we really need to be able to adjust the percentage of oxygen in the hood. And that would also serve more positively, I think, for the patient to keep everything, again, inside the hood rather than having to switch over like we do when we have to feed them or give them something to drink.
So another thing that I noticed too, the testing. It was pretty hard probably to do the ABGs on all these patients, just like because of the low resources during the pandemic, and everybody is busy with the patient flow and everything. So did you do any ABGs for these patients?
ABGs were few and far between.
Okay.
We primarily used O2 saturations and patient's clinical status.
Okay. Any feedback from the patients? Good, bad? What can get better?
The ones that survived, we had a number of letters back to us thanking us for keeping them from being intubated.
Okay.
I can remember how uncomfortable they were. And when they got the hood on, they became a bit more comfortable. And again, enough to hold them over. And I think that, how do we prevent them from getting intubated? Well, I think that by not intubating them right away, we decreased their mortality chances. We also gave the medications they were getting a chance to work. Again, I don't think we really know what was working and what wasn't at that point, but whatever we gave them and had a little more time to circulate around their system, maybe do some good, decrease inflammation, decrease edema.
Yeah, it's like, non-invasive ventilation, or even the invasive ventilation is not treating the COVID. It's just giving that time so the other treatments can start working.
It's the bridge. It's the bridge.
It's a bridge, exactly. You just prolonging that time, giving another chance, another day for that patient to recover faster.
Right.
So now, when you decided to use helmets for the COVID patients, how did you, what was the response from leaders in your hospital, the decision makers?
The leaders in the hospital were on our side. They wanted to try it. The benefactor's daughter, who actually brought it up to us, donated a fair amount of money, so we went right ahead and ordered 100 hoods in advance. Since we are a multi-place facility and we use hoods on a regular basis, we do have a contact. I won't mention the company that we use, but they were nice enough to send us the hoods right away, even though there was a backlog. Where we had the most difficulty, I really think, was with the respiratory department. And the reason Surprising, right?
Yeah.
So the reason why I think we had that issue was because of staffing.
Okay.
So we had these people who were working extremely hard, many of them working overtime, and they were managing ventilators, they were managing oxygen flow problems, they're managing high flow nasal cannulas, and there was a limited resource and very few people to be running around with oxygen tanks. We had one area of the hospital that didn't even have oxygen in the walls. So they had to actually bring in tanks for
Wow.
people. So that's because we were getting so full and the demand for rooms for these patients. So the respiratory department, I think, probably gave us as best cooperation as they could under the circumstances. So we actually closed down the hyperbaric medicine department for elective treatment. So we had all the hyperbaric technologists who were also in our institution, emergency medical technicians. We had them all working on the floor, helping the respiratory department.
Okay.
With the hoods, with the tubing, with the high flow meters, with everything that we needed. We gave them assistance with moving tanks, etc.
So they became like champions for the helmet and IV.
Yeah, and I think that it was tough also from the nursing standpoint because the nurses are unfamiliar with this. So we would go up there and we would show the nurse taking care of the patient what we were doing and how we would do it. And we'd show them how to put the neck ring on and how to put the hood on, how to connect it to the wall oxygen, the fact that the wall oxygen had to go up higher than fit. Once you get to 15 liters, keep going until you can't open it anymore, right?
All the way up, all the way.
And so once you did that and you left the room and you were off going to another room, now you've left a nurse there who's gotten basically the 3-minute in-service on how to use a hyperbaric hood. And when the patient all of a sudden complained that they needed to get a drink or they needed to eat something, the nurse was kind of stuck. They'd call us, but maybe we couldn't get right back to the room and the patient really wanted the drinks. So we found nurses that were just taking the hood by the neck ring and pulling it up over the patient's head, and then pushing it back down over the patient's head, So, and then they probably weren't flushing the oxygen meter either. They were probably going to 15 liters, which is what they were taught, what they were used to, right?
Yeah.
They didn't realize you could actually open it all the way up to flush it. So I wonder, again, how many of those patients that required intubation on the hood were actually not getting the proper flow that they needed to maintain them. So there were a lot of variables that this time around we know that we have to look at to give the patients the better chance.
So here I have a question. Did you notice that some of these patients failed NIV because of the neurological changes? Because that would be like one of the causes for the, one of the symptoms for the CO2 breathing.
I think that, there were a couple of hoods also that were like fogging up. And then when we went up to the room, we flushed the oxygen meter and we cleared up that problem. But, I wonder how many of those patients had that issue and wound up getting intubated.
Because of the fog.
And because we weren't there to adjust it, the nurse wasn't sure at that point that it had to be full flushed.
Oh, well, it's really amazing what you did with with minimum education, with just having your staff helping everybody else there, implementing new system, which is actually easy to use when you learn about it. But like little things can make it fail. Like you said, taking off the hood.
Yeah, it's not necessarily the hood or the oxygen, but like everything else, a computer's a great thing as long as you know how to use it.
Yeah. So education, definitely.
And there's definitely a pullback from people to want to learn something new, especially in the middle of that pandemic, right? Nurses were already, they had IV lines running under the door, outside the door. They were, running from this patient to that patient. Most of them had one patient at a time, so you can imagine how many people are on the floor.
Yeah.
But with all these things to take care of, all these new medications they weren't used to using.
With proning, there's so much proning was going on too.
So there was so much going on to remember, to fully flush the oxygen from 15 liters, how to properly take the mask off and on, the hood off and on, to ask for help to do it, right? So yeah, I think that if we can get through at least some type of nursing in servicing and nursing assistant in servicing with the hoods, and everybody's on the same page with how it has to work, I think that our numbers might look a little better.
Yeah. Well, now a few more technical questions. So you use the helmet CPAP setup. So that's connected to the flow, and then you had a PEEP valve. What PEEP did you use most of the time?
We started with a PEEP of 5.
Okay.
And then
you
we'll go to
were
PEEP of
adjusting.
10.
Okay.
And after a while, anesthesia, we had meetings with anesthesia and critical care. And then they were talking about how maybe too much PEEP is not good. You know, there was a point where a lot of PEEP was not good.
Okay.
So then we weren't, you know, I think we got to a point where we didn't really push the PEEP up higher than 5.
Okay. Is that when we started to talk about the SILI, the self-induced lung injury?
Yes.
Okay. Yeah, and that's what I'm hearing, that you have to ventilate gently. That was like, you know, the message from Italy also, that ventilation should be gentle. And especially, you know, when you connect to the BiPAP or ventilator, so the inspiratory pressure is very important. They don't want it to give too much volume, because that's the major cause for the lung injury.
Oh, and that goes back to ARDS from years ago, using jet ventilation and, you know, lower volumes and higher rates.
Yes, exactly. Now, what was the staff feedback after you were done with the study, when we actually saw the benefit of the helmet ventilation? Did we change their opinion about it? Are we
It's still
willing to try it again?
It's still tough. So we're at the point now where we are having meetings about where the oxygen hoods or helmets should fit into the respiratory policy.
Mm-hmm.
So they have the policy, like when we're going to put people on high pressure positive ventilation, right?
Mm-hmm.
High flow positive pressure ventilation versus using a hood, you know, and versus getting intubated. So.
Are there any ideas to actually start that early? Because as you know, and as all the listeners know, the success for the non-invasive ventilation is the timing, when you apply it. And even the studies from Italy showed that pre-admission helmet application helped with survival rate for the pulmonary edema patients. So are there like, do you think you're gonna have it in a policy that the hood should be applied in ER when patients just get admitted? You don't have to wait for the ICU.
That's the discussion that's going on now. So I think that they were still looking at it like, you know, well, the hood should be used when the patients are getting bad, and we're trying to institute it as a primary usage for patients having respiratory difficulty. So I'd like to see the hoods used right away. And again, I don't think it would be unethical to do a prospective randomized trial of high flow nasal cannula per se, any other, you know, the usual types of high flow positive pressure versus high flow positive pressure on the hood, and see who does better.
Well, you know, even with when I look at your numbers, so 39% of patients avoided intubation with the helmet. And I just want to, you know, again, note about that these patients are the sickest ones. So we failed all the other treatments, all the oxygen treatments that we had in the unit. And you still had a very high percentage of patients who avoided intubation. Because in Italy, we were, you know, again, it depends on the hospital. We were saying about 20%. It went up to 40% later. But that shows how successful you guys were in your facility. And I would like to ask you if you can share, based on your experience, any tips for other institutions. What steps we should take and focus on to make sure that helmet-based ventilation is implemented successfully and appreciated by not just the patients, but the staff also?
Well, I think it's definitely important for them to have early meetings with their pulmonary critical care and anesthesia departments. I think it's important to disseminate the information that's now available to us regarding the hoods, information that came out of Italy, information from the University of Chicago, and anybody else who's managed to get some published data there for the use of the hoods. And again, I think that if we can find a number of people that might have a question as to whether or not there's benefit, then I think, again, doing a prospective randomized trial would be a good thing to do. If you're having a hard time convincing them to go to the hood as a primary mechanism of preventing intubation, then let's at least compare it to what you're saying is better. Now, let's take a patient who you're going to put on high flow, and we'll put one on a nasal cannula or a mask and the other on a hood. And let's compare them at the end of the hospitalization, the same way we did, right? Saturations, how they improve, in-hospital mortality, in-hospital mechanical ventilation need, right? So these are all things we can follow. And if we have multiple places doing it, we'll have that many more patients to put in the study to make it statistically significant.
Yeah, definitely. More studies will help a lot. Even that our colleagues in Italy already made a lot of studies on patients who don't have COVID, and results are great. One more thing about your patients. Did you do any proning? Were the patients encouraged to change the position, be prone? And well,
here, our institution found that proning was definitely a plus.
Okay.
So when the patients were on either high flow nasal cannula, or they were on a mask, or they were on a hood, we still managed to prone the patients with a hood.
Okay.
So it's a little more difficult in the sense you have to get some, either a pillow underneath them or get the ring of the hood up over the end of the bed. It was a little difficult to get them to prone comfortably, but we were able to get the majority of patients to prone with the mask, with the hood that was necessary.
Okay.
If their SATs were good without proning, that was fine. If the SATs looked like it was dropping with the hood on still, then we would prone them. And some patients did well with that. Some didn't, but some did.
And then now the first hours after the helmet applications, the patient has to be watched very closely, because those are the most important couple hours where you will see where that's going to turn, if it's going to get better or worse. Did you notice the same thing with your patients? Like, what would be the timeline where you really will know if we have to get ready a ventilator outside the room, or we can be okay with this patient on a helmet for a couple of days?
Well, I think that in a perfect world, I know if we had a couple of hours to sit there and watch the patient and take notes and see how they were doing, that would be great. However, once you get the patient in the hood, the patient's now positioned comfortably. We usually with them for the first 20 to 30 minutes.
Okay.
If they're not claustrophobic, they're not looking to rip the hood off. They look fairly comfortable. The hood's not fogging up. Saturation looks improved. Those are the patients that at that point we'll walk away from to go to the next patient, because that's how it was, going from room to room. But we would always come back and check on the patient. So we made rounds on the patients from the hood standpoint 4 times a day.
Okay.
So twice a shift. We ran 12-hour shifts, so every 6 hours at least, someone from the Hyperbaric Medicine department would go up and check on the hood. And then we also had Voceras, the machines where you can just dial the extension and ask for us. So that anybody could dial the extension and just say hyperbaric technician, and we'd get the phone call and we'd go right up if they were having an issue.
And then did you use any like light sedation for patients who felt anxious? Because definitely I can imagine them, seeing a helmet for the first time in life and then wearing it. It's probably very, frightening experience. So did you use any medication for that?
The use of anti-anxiety medication in the hyperbaric department is not unheard of. It's certainly something we consider. One thing I definitely find is that before going to an anxiolytic, the doctor going into the room sitting with the patient for a minute, letting them know it's okay. Sometimes that works. For some reason, they feel if the doctor comes in, it must be okay. If he's sitting there and tells you it's okay, it's better than the nurse telling you it's okay, or it's better than A telling you it's okay, or, not that it is any better, because behind every good doctor is a great nurse. So, unfortunately, sometimes the patients look at that a little differently. So, sometimes that works, sometimes it doesn't. I can tell you that myself, from the standpoint of dealing with patients in respiratory failure, sometimes I think using the anxiolytics is a little bit of a problem because of more respiratory decline, and then fighting with the anesthesiologist and the critical care specialist over that. Nobody wants to really give a anxiolytic to someone who's already having a problem breathing. Some people will, and some people won't. Sometimes I think the anxiolytic may actually calm them down a little bit, where the tachypnea doesn't overwhelm them, and they feel a little bit better. And sometimes the tachypnea, may make a saturation worse. If you slow the breathing down, slow it down to nice deep breaths, and might improve the saturation. So I think there's pluses and minuses. From the medical legal standpoint, I think a lot of doctors are a little bit negative about writing any kind of mood altering medications for people who are already having a hard time breathing.
Yeah.
But I don't know what your experience is with that.
Well, I heard from other facilities we did use anti-anxiety medications, but again, it depends on the patient, on the patient's history too. It's not, so it has to be very individualized, decision for these patients. Anything else would you like to say, to share, or to say to our listeners?
Well, I would just say, start, plan early. Make the plan and then follow your plan, and try and get everybody on board to follow the plan with you. And, if they don't want to follow everything that you're doing or anything you want to implement, there has to be a happy medium somewhere. And like everything else we do in medicine, break out the data and show them the studies and say, look, this is what's happening in Italy. This is what happened with ARDS patients in Chicago. This is what happened with hood patients at Phelps Hospital Northwell Health. So there is definitely something pointing to the fact that the hood might be the better route to take.
Well, I can just add to it, and my suggestion would be, if any clinicians out there have, work with hyperbaric medicine experts, that would be the first step to do. It's actually contact them and work together, because you guys are the experts in this field, and it would be easier to create the protocol for the helmet and IV use. Again, on our website, you can find a lot of guidelines, a lot of protocols that are shared by the University of Chicago, by the Pennsylvania University. So these pages are updated on a daily basis. When I have something new, I always make sure it is out there. And thank you very much, Dr. O'Neill. And it was a pleasure to talk with you. Thank you for what you do, and thank you for saving lives.
And thank you for having me.